recording because we are obviously going to share that afterwards. So, hello for everyone who is joining online. So we have the pleasure today to be here with Dr. Christina Papayanidis. I hope my French accent made it sound correct.
That's fine.
Yeah.
Yeah.
And we are going to speak about a complex topic. For most of us, is very new. So it's BPDCN, and you will know more about this in a few minutes. So you have the opportunity to ask questions in the chat box, or there's a Q&A function. I'm going to monitor that during the talk, and we can address the questions afterwards. The other possibility is that if there are not too many people online, I can switch the setting from webinar to meeting, to meeting. So then you will be able to ask directly your question. But I will also monitor that during the presentation. So this is going to be recorded. The slides also are going to be shared. So thank you, Christina, for that. And it's going to be made available on the Alan website and on Facebook for people who have access to Facebook. And I think that's it. So I pass over to you, Christina. Thank you so much for joining us today.
Thank you, Samantha. Good afternoon, everybody. It's a great pleasure for me to share with you my experience on BPDCN. I'll try to give you an overview on the disease, on the diagnosis until therapy. Please interrupt me whenever you want. I would like you to just to create a very informal atmosphere in order to understand, to make you able to understand it as much as I can. So these are my disclosures. So we are talking about a very, very rare disease. Perhaps it's one of the rarest diseases in the experience of every hematologist worldwide. We must say that BPDCN accounts for 0.4% of all hematological malignancies. So it may happen that during a whole life, one hematologist is able to detect only one patient or a couple of patients or no patients at all. But it's a very aggressive disease. That's why we all need to know about this, because the prognosis is very, very dismal. So it's very, very important to recognize these patients. Also because today we have a treatment which was not available in the last few years, and so we can give the patients the opportunity to be cured. The exact incidence of this disease is difficult to estimate due to its rarity, and also due to the fact that the terminology of this neoplasia has been changed over time, and we will see it in the last few slides. An estimated 1,000 to 1,400 cases annually in the US and Europe combined is reported, but as I mentioned before, we are not sure about this data. Perhaps there are more cases which have not been recognized so far. And what we know today is that it's a disease which typically involves middle-aged patients with a median age of diagnosis in the mid-60s, with a higher prevalence in males compared to females, with a sex ratio of 2.5 to 1. But we also need to be aware of the fact that also pediatric cases have been diagnosed and have been described in children as young as 8 months of age. So it's a malignancy which may involve all the people, regardless of age. And BPDCN stands for blastic plasmacytoid dendritic cell neoplasia. And which kind of cells are we talking about? We are talking about plasmacytoid dendritic cells, which are the most common dendritic cell subset in the peripheral blood. Less than 0.1% of all mononuclear cells which are circulating in our blood. They have an important role. In particular, their role is represented in this cartoon in the setting of innate immunity, because these cells are able to secrete high amounts of type 1 interferon, in particular interferon alpha and interferon beta, which are very, very important in response to virus, but also bacteria, but in particular to virus. So they play a key role when we have to face with the virus during our normal life. If they transform, if they develop malignant cells, they can give rise to this kind of disease, which is called BPDCN. As I mentioned before, only in 2016, BPDCN has been described as a new entity because in the previous WHO classifications, it was considered together with lymphoma or with acute myeloid leukemia, but only in 2016, a new entity including only this kind of disease has been described. And this frequent reclassification and renaming has contributed to under-recognition of this kind of disease. These are the two last classifications we are using in our clinical daily practice at the WHO and the ICC. And in both classifications, we can find the stick plasmacytoid dendritic cell neoplasm definition. A difference between the two classifications is due to the fact that in a WHO, a new entity has been added, which is represented by the so-called mature plasmacytoid dendritic cell proliferation associated with myeloid neoplasm. So another kind of disease in which we can find, again, a particular group of plasmacytoid dendritic cell which proliferate, but these are mature cells. So these are different from the cells which we usually recognize in the BPDCN. So it is another kind of disease. The BPDCN, the classic BPDCN, has this kind of name in both classifications, as reported here in yellow in the WHO and in the ICC. The clinical presentation of this disease is very, very, very heterogeneous. That's why sometimes it can be difficult to detect these kind of patients. And it's very important to recognize early these patients because we know that if we wait for too long, unfortunately, the disease evolves and the transformation to leukemia, unfortunately, happens in all the cases. And if we wait for too much, then it's difficult to have a cure which is effective in this kind of disease. So it's important to detect these patients at the very, very, very beginning without waiting for so long. And if we have to recognize something, we have to know that something exists. Otherwise, we can see all these patients, but if we don't know that BPDCN exists, we are not able to recognize and to cure this kind of patients. That's why it's important to share knowledge and to create network in order to share what we know so far about this kind of neoplasia. And the impact of treatment delay is shown here in this paper, which has been published last year. We can see here that if we have a treatment delay, unfortunately, the outcome is worse. You can see that the gray line, if we wait for 3 to 6 months, the outcome is worse compared to all the patients who are treated immediately as soon as the diagnosis is made. And this is an important point. I was mentioning before that the clinical presentation is very, very heterogeneous. It means that we can see the same disease with different features in different patients. What we know is that in about 80 to 90% of patients, skin lesions are present. So not in all the patient populations, but in more than 80%. A significant rate of patients, about 50% of these patients, present also with the bone marrow involvement and the lymph nodes captation. Unfortunately, when we see that bone marrow is already involved by the disease, is always late. I mean, therapeutic approaches may be less effective compared to what we can obtain in terms of response if we start treating patients when only the skin is involved. But other extracutaneous sites may be involved, in particular spleen, liver, and very, very important to highlight CNS. CNS also may be involved in other kind of hematological diseases like leukemia, lymphoma, multiple myeloma, and so on. And also in BPDCN, we can find BPDCN cells in our CNS, and this is a point to be stressed because we must give intrathecal chemotherapy to these patients in order to reduce the symptoms and all the features that the CNS involvement may induce. In few cases, BPDCN may present with bone marrow disease without skin involvement. These are very, very rare, but these have been also described. And when we talk about skin involvement, you can see here from these pictures that we may have different kind of lesions, which can vary in terms of size, shape, color, and distribution, because they can be recognized in different parts of our body and can be confused with other benign or malignant skin lesions. That's why it's so important that dermatologists are skilled on this topic in order to recognize that this is BPDCN and this is not urticaria or lymphoma or other things, because of course the therapies are different. These lesions may appear to be indolent at the very beginning, but as I mentioned before, progression invariably occurs with involvement of other sites, including bone marrow, liver, spleen, and CNS. So even if at the very beginning a person could say, okay, it's just a skin lesion, it's nothing, I can just wait and watch, this is a big mistake, because waiting means wasting time, and wasting time means that at the very end, unfortunately, therapy will be less effective. So sharing knowledge is important in order to recognize these lesions at the beginning and to immediately start all the therapeutic approaches we have. And now I've just reported the two most frequent clinical scenarios we can face with in our daily practice. I am a hematologist, so I usually receive patients from dermatologists or from general practitioners, quite rarely, unfortunately, or from an emergency unit. This is the first clinical scenario. What may happen is that the person at a certain point of his life notices a skin lesion in his body, okay, quite atypical. In Italy, at least, it happens that he usually refers to his GP, so general practitioner, and the general practitioner should be able to send the patient to a dermatologist who should make a biopsy in order to understand which kind of lesion is. But unfortunately, what happens? It happens that the general practitioner says, okay, it's nothing, you can wait. And waiting, as I mentioned before, is a very, very bad solution. When the dermatologist sees the patient, he should perform a biopsy without waiting. And after biopsy, the pathologist should be able to make the right diagnosis. But what we have learned so far and what we know is that, unfortunately, the pathological features of these kind of diseases may be misdiagnosed or underdiagnosed, because some features overlap with other diseases, like some kinds of leukemia or lymphoma and so on. That's why we need to have skilled pathologists as well in order to allow the patients to receive the correct diagnosis. And every time you see in my slides the challenge, like here at the bottom of my slide, it means that it's something we should try to improve in order to improve the diagnostic process, in order to improve the outcome, the final outcome of our patients. What we know from literature is that it usually takes 6.2 months from the onset of lesions, of skin lesions, to the diagnosis in BPDCN. But from my personal experience, and I've seen quite a huge number of patients with BPDCN, even if it's a rare disease, because my site is a referral site in Italy, I must say that unfortunately, this window time is longer than 6.2 months. I've received patients waiting for a diagnosis for more than 6 months, also 1 year or more than 1 year. And unfortunately, at that time, when they arrived, they were already in very, very bad clinical conditions with no opportunity to be cured. The second scenario occurs when the patients, unfortunately, have a very, very advanced disease. So they have already developed the signs and the symptoms which characterize bone marrow involvement. So these are the symptoms of leukemia. And so they usually go to an emergency unit or directly to an hematology unit because they have anemia, thrombocytopenia, leukopenia, because bone marrow is completely how can I say, full of these BPDCN cells, like a leukemia. Again, at this time, skin lesions may be present or not, but it doesn't matter because the prevalent symptoms of the patients regard the bone marrow involvement. And the hematologist plays the key role at this time because he has to perform a bone marrow evaluation, a bone marrow biopsy. And again, the pathologist needs to make the right diagnosis and so to differ this kind of disease from other diseases which may have some features which overlap, like acute leukemias, lymphoma, and so on, as I mentioned before. And again, also this kind of process is a challenge because we need to have skilled pathologists, we need to have skilled hematologists who immediately perform a bone marrow evaluation, and we need not to waste time. So, as reported here in my slide, this is a disease which requires a multidisciplinary approach because, okay, we have the patient in the middle, and around the patient, different figures of professional healthcare, like hematologists, dermatologists, pathologists, GPs, which must be involved from the beginning, but during also all the therapeutic path of the patient, in order to improve the outcome and to improve the general management of this kind of conditions. It's easy to report this kind of concept in a slide, but it's not so easy in the daily practice because working together is not, I can say, easy also from a logistic point of view. We need to interact, we need to have the possibility to talk each other, and it's not always possible in our real practice. So the diagnostic workup, as I mentioned before, involves many different physicians, and not only physicians. The role of the dermatologist, of course, is really, really important, and they have to recognize these lesions and to perform the biopsy. The role of hematologists as well is important because we have to perform a bone marrow evaluation, and with bone marrow evaluation, we have to test a lot of aspects that we usually analyze when we study leukemia patients. And in particular, we start with morphology in order to see which kind of cells are present in the bone marrow. And I don't want to go into details, but just to show you the heterogeneity, also from a morphological point of view of a BPDCN, saying that we can find typical BPDCN cells in the left of my slides, typical morphology, but we can also find cells which are really, really close to lymphoid leukemia or a monoblastic leukemia. So when I say that they may overlap, this is the meaning. I mean, we can find something which is usually found also in other diseases. And again, skills are very, very important in order to recognize the right diagnosis. But this is an important point. The last WHO classification has really pointed out all the features that must be present in order to make the diagnosis of BPDCN. So we have a document which is able to tell us what we have to look for and what we have to find in order to say, okay, this patient has a BPDCN and has not a leukemia or has not a lymphoma. And in particular, the exam, which is the most important one, is the flow cytometry test, in order to highlight the antigens which are expressed by these cells. And I don't want to go into details, but we know today very well that in particular 3 antigens, which are quite easy to be memorized because are subsequent numbers, CD1, 2, 3, 4, and 56, must be present together with others in order to make the diagnosis of BPDCN. The hematologist has to perform the bone marrow evaluation, but as I mentioned before, we know that also CNS may be involved by BPDCN, so we have also to perform a lumbar puncture. Lumbar puncture means go into the CNS in order to test if in the fluid of CNS there are BPDCN cells. And this is something we usually do in patients with acute lymphoblastic leukemia, and we have to do the same in BPDCN patients. And the reason is that, unfortunately, both at diagnosis and at relapse, a CNS involvement may be detected, and that's why we need to perform lumbar punctures at diagnosis and as prophylaxis over time during treatment of BPDCN patients. This is an experience from Houston, MD Anderson, showing that 22% of the patients treated at their institution with BPDCN had a CNS involvement, so a quite high rate of patients. And in particular, these patients had specific mutations in their neoplastic cells, just showing a very, very aggressive signature of this kind of BPDCN compared to others in which CNS was not involved. And we know today, thanks to a lot of studies which have been performed, in particular this one by the Italian group of Professor Pileri, that patients who have a CNS involvement have an overexpression of some genes which really are able to create like a crosstalk between BPDCN and CNS, and so to establish like a tumor supportive niche in central nervous system, and to make these cells able to go out from bone marrow and to go into CNS. Another important exam which has to be performed at diagnosis is the PET-TC. PET-TC is usually done in lymphoma patients in order to find solid localizations of the disease out from bone marrow, like lymph nodes, spleen, or others. And this is important not only at diagnosis, but also over time in order to assess the efficacy of the treatments and to see if some localizations which were present at the beginning then are able to disappear over time thanks to the efficacy of the drug that we are giving to the patients. Last but not least, I'm an hematologist, so I usually study leukemias, not only from a morphological point of view, but also in terms of DNA alterations, starting from cytogenetics, and so chromosomal aberration, and then going down to mutation of genes or other molecular aberrations. And in particular, what I want to try to tell you is that in BPDCN, there are a lot of alterations in DNA because it's a very aggressive disease. And we can find the loss of chromosomes. We can find the overexpression of a lot of genes, which unfortunately induce a damage in DNA. And that's why what happens after this damage is an unchecked proliferation of BPDCN cells, and so giving rise to this kind of disease. In particular, we can find abnormalities which usually are present in myeloid leukemias, but we can also find abnormalities we can detect in lymphoid malignancies. So it's like a mix. a mix coming from two different worlds of diseases. And for this reason, so far, when we had only chemotherapy to be used for these patients, sometimes we were used to treat patients with myeloid-like schedules and other times lymphoid-like schedules, because from a pathogenetical point of view, both alterations were detected in this kind of diseases. So we have a very aggressive disease, and unfortunately, when a disease is rare, it's also more difficult to treat these patients because we don't have experience. And so we need to share our experience in order to improve the outcome of our patients. And we need to put together other cases in order to make the most appropriate decision regarding treatment. We have guidelines, even if it's a rare disease, we have guidelines. In particular, this is the last version of the NCCN guidelines showing the recommended approach we should use today to treat a patient with BPDCN. A patient, as I mentioned before, who can be a young patient, an elderly patient, a child, or an elderly man or an elderly woman. So everybody can be, unfortunately, involved. At the very, very beginning, you can see here, the most important thing we have to do is to define if the patient with BPDCN is fit, is candidate for an intensive approach. I mean, is it this patient in good clinical conditions in order to be able to receive an intensive approach, or on the other side, unfortunately, the disease is already so advanced, in an advanced phase, that we can just give him palliation and best supportive care. If the patient is in good clinical condition, and we hope to have more and more patients in this group, because otherwise it means that, as I mentioned before, we are still waiting too long from the onset of lesions to diagnosis, and it's a very, very big problem. So if the patient is fit, we have a lot of options today. But the very first option today is a great drug which has been approved in Italy last year, but by FDA in the US many years ago, which is tagraxofusp. Tagraxofusp is an antibody, so it's not chemotherapy. It's a very revolutionary agent, which is able, and I will show you the data in the next slides, to change the natural history of this kind of disease. Before TAG, we just had chemotherapy. So until a couple of years ago, we had only the opportunity to treat patients with chemotherapy, as we usually do in leukemia or in lymphoma. The aim of the treatment we have to start for these patients is only one, and it's to make these patients able to achieve a complete remission. Complete remission means that when we perform a bone marrow evaluation, we don't see BPDCN cells at all. Complete remission means that all the skin lesions disappear. And it means also that the CNS is clear and that there are no BPDCN cells involving this tissue. So it means that we don't see any signs or any symptoms or any alterations related to BPDCN. The problem is that when the patient achieves a complete remission, we can't say, okay, we have win the battle, it's over, the patient is fine, and we don't need to do anything more, because this is a disease which has a high rate of relapse. If we stop after the achievement of CR, in a medium time of 6 to 10 months, a relapse will occur. So we need to consolidate the complete remission we achieve with a transplant, in particular with an allogenic stem cell transplantation. So we have to collect cells from a donor, a healthy donor, and we have to perform a transplant, as we usually do for leukemia and for some kinds of myelodysplastic syndrome or other hematological diseases. So it's important to have in mind that any kind of treatment is not enough to cure the patients in the long run. We can achieve a CR, but then we have to go to transplant. This is what we had before tagraxofusp. So we had only chemotherapy. We were used to administer myeloid or lymphoma-like schedules. But the point was that even if in the short run, the rate of complete remission was high, 60 to 70%, unfortunately, only a minority of patients were able to proceed to an allogeneic stem cell transplantation because they had a lot of adverse events, a lot of toxicity related to chemotherapy. So they achieved the response, but they developed infections, pneumonia, and other adverse events, which contraindicated the transplant, because you know that the transplantation is a very aggressive approach, which needs that the patient is in good clinical condition. Otherwise, he's not able to face with this kind of treatment. So chemotherapy is active in the short run, but unfortunately, only few patients were able to be transplanted. And so in the long run, the prognosis of these patients was very, very poor. I mentioned allogeneic stem cell transplantation, and I want to show you just briefly this data coming from the CI-BMTR, so the American Registry of Transplanted Patients, showing that if a patient is young, achieves a CR with the TAG or with other agents, and is able to go to transplant, this is the best situation we may have, because these are the patients who will have the best outcome ever. On the other side, if you transplant a patient with an active disease, so with a patient with a disease which has not achieved a complete remission, unfortunately, the long-term survival, which will be very, very poor. So we were forced to use chemotherapy for many, many years, in particular until 2018 in the US, until 2020 in Europe, and until last year in Italy. But it was really a great revolution. A new drug has been approved in 2018 in the US, in 2020 in Europe by EMA, and in Italy last year by our Italian regulatory system, which is called tagraxofusp. This is not chemotherapy. This is an antibody, so a revolutionary kind of drug. In particular, this is an antibody which is directed to CD123. CD123, if you remember, is one of the antigens which must be expressed by BPDCN in order to make this kind of diagnosis. So it's really a hallmark of the disease. In particular, this is an antibody which is conjugated with a piece of diphtheria toxin. When this antibody is linked to the neoplastic cells, it goes into the cell, and then the diphtheria toxin is released and is able to kill the cells, inducing apoptosis. So the cell is able to die. This is a very innovative approach to treat this kind of disease, but also in general to treat an hematological malignancy. We don't have so many antibodies like this to be used in our clinical practice. So a very, very relevant step forward. And the TAG was approved thanks to the results of a phase 1/2 trial, which was run by MD Anderson, by our friends in Houston, which was published in New England, which is one of the most important journals in hematology, in 2019. You can see here that the patients treated were only 32 in the cohort of untreated patients, so newly diagnosed, and 15 in the cohort of patients relapsed or refractory after previous lines of therapy, just to highlight again how much this disease is rare, because in a big center like MD Anderson, involving also other institutions in US, only 32 and 15 patients were collected. So overall, 47 patients who received this drug, which is given with intravenous infusion for 5 days every 21, with a very short infusions, which is just 20 minutes, so very, very short. The primary endpoint of the study was to understand the rate of CR, so how effective this drug can be both in newly diagnosed patients and in heavily pretreated patients, and how many patients are able to achieve a complete remission. As I mentioned before, complete remission is our aim, but after CR, we have to go to transplant. And I want to focus your attention in particular to the treatment-naive patients, so the 32 newly diagnosed patients. You can see here that they had a median age of 68, but there were also very young patients, 22, and also very elderly patients. 84 was the highest age. Skin involvement was present in 97% of the cases, and bone marrow involvement in 47%. As I mentioned before, these are more or less the numbers we usually see in our clinical practice. 75% of the patients achieved a response. So the overall response rate was very, very high. And if we put together all the population of newly diagnosed patients with a median follow-up of 34 months, the median overall survival was 15.8 months. Someone can say, okay, good results, but not so exciting. But what is the point? The point is that unfortunately, most of these patients were elderly, and so they were not able to proceed to an allogeneic stem cell transplantation. If you look at the right part of my slide, all the blue curve regards all the patients who achieved the CR and then proceeded to transplant. And you can see here that in the long run, 50% of these patients are cured, so without any kind of relapse. This is an extraordinary result. I mean, for people with experience in BPDCN, we were not able to see any kind of patients cured in the long run before the introduction of TAG, because also after transplant, unfortunately, many kind of patients were used to relapse. And this was like, something that we were not able to change. This kind of drug has really given an improvement in the long-term survival of these patients. And we can say today that 50% of the patients achieving CR with TAG and going to transplant are able to be cured in the long distance. When we talk about a new drug, we have to take in mind that we may have toxicity. It's a different mechanism of action. So which kind of adverse events may occur, and how can we prevent them? Data from literature and also from our clinical practice treating patients say that this drug is very manageable in terms of safety profile. But during the first course, we need to hospitalize these patients because a kind of toxicity, in particular in terms of liver toxicity, may occur. This is something that needs to be managed in an inpatient setting. And then starting from the second course and beyond, we can manage this patient in an outpatient setting. So seeing them in the morning, and then they go home in the evening, and they come back again the day after to receive the second day of treatment, and so on. But the first course needs to be given in the hospital. Liver toxicity is important, and the other kind of toxicity we have to take in mind is so-called capillary leak syndrome, CLS, which is typical of this kind of drug. And I just want to show you briefly that capillary leak syndrome is characterized by typical signs reported here, which are due to the fact that the drug may induce a damage to the capillary of these patients, so inducing a loss of protein from the vessels to the extra vessel space, and so leading to hypotension and other kind of adverse events. But if the patient is hospitalized, we are able to recognize very early these kind of signs and symptoms and to treat these patients properly. That's why we need to have these patients in our beds at the very, very beginning. As I mentioned before, the overall response rate of TAG is 75%. So it means that 25% of patients, even if they have the CD123 overexpressed, don't respond. And we don't know exactly why it happens. There are many studies ongoing trying to elucidate the mechanism of resistance to this drug or of loss of response to this drug. This is a paper which has been published recently showing that the mutation of specific points in the DNA may have a role in inducing the loss of response to TAG or the resistance, the primary resistance to TAG. But these are very, very preliminary data just to show you that okay, we have an effective drug, but the research is still working because we still have to learn a lot and we still have to understand a lot of things regarding this drug and regarding this disease. And the research is still ongoing also regarding other targets and other potential drugs which may be introduced together with TAG or in place of TAG and to improve the results in the long run of our patients. This cartoon shows other drugs which are in clinical development. In particular, one of these is called venetoclax, which is able to target another pathway, which is called BCL2, which is overexpressed in BPDCN. And there are many data from the lab to the clinic to the patients showing that also this drug may be active in this kind of patients. And this is just a table to show you that there are many clinical trials in the US mostly, but also in Europe, combining different approaches in BPDCN with triplet combinations, some based on TAG and some others not, in order to find out more effective approaches. So in this slide, I just wanted to recap the most important messages I would like to share with you regarding this kind of disease. So the first message is that this disease requires a multidisciplinary team. So a hematologist alone is not able to cure a BPDCN patient, a dermatologist as well. We need to work together and we need to create multidisciplinary teams. Yes, teams. I think that team is the most appropriate word. In order to start following these patients together from the very beginning and going on in the same way over time. An early accurate diagnosis is essential because if we wait for too long, we waste time, and then at the very end, the disease is difficult to be treated and is more resistant to treatments. So we need to share knowledge in order to make dermatologists able to immediately recognize that this lesion is BPDCN and to refer the patient to a hematologist and then going on with all the diagnostic workup I've shown you in my presentation. And we also need to know that allogeneic stem cell transplantation is mandatory. So it's something that needs to be considered from the beginning. We need time to search for a donor. We can't find a donor in a week. So immediately at diagnosis, we must start searching for a donor in the family, in the registry, in order to be ready after the achievement of CR to proceed to an allogeneic stem cell transplantation. So the role of time is crucial. In general, in all the hematological neoplasia, but in particular, is really, really crucial in BPDCN. In terms of treatments, we have chemo, okay, chemotherapy is available, but the novelty today is tagraxofusp, a new agent with a different mechanism of action, very manageable in terms of safety. We must know that some kinds of adverse events may occur, but we must know that we know how to manage them properly. And so we need to treat these patients in the right setting and to give them the highest possibility to reach a complete remission. This is what we know. There are a lot of things unknown in terms of mechanisms of resistance, how monitoring the minimal residual disease, how can we stratify patients in order to understand from the beginning if a patient is will have a worse prognosis compared to another one. Unfortunately, it's a rare disease, so we don't have so many patients to perform this kind of speculations. But if we work together and if we put together our cases, perhaps we can achieve better results. What's next? I think that these are the three main points we need to be focused on. This is not only for BPDCN, but in general, for all the rare diseases we have to face with. In particular, we need to improve expertise. As I mentioned before, creation of multidisciplinary teams is mandatory, and sharing knowledge is something we really need to be focused on. The aim is to improve diagnosis and to identify very quickly the right patient with the right disease, reducing delays to improve outcomes, and to make these patients able to be treated with the most appropriate drugs. And today we have a really, really effective drug, which is called tagraxofusp. Last but not least, I would like just to show you and to share with you our experience in Bologna with the TAG. As I mentioned before, it's a rare disease, so I only have 6 cases to share with you, but let me say that it's not a small number, because in some sites in my country, no patients have never been detected. So 6 patients, young patients, elderly patients. In particular, in the red box, I've showed you 2 patients who have achieved a CR with TAG and then have been transplanted, and today they are alive after more than 2 years for transplant. So I can say they have been cured, definitely, and it's a great result. But we also have a very elderly patient. You can see patient number 6, a 91-year-old man, who developed a left leg skin lesion in January 2023. But unfortunately, a biopsy was performed only in June, so 6 months later, because his GP usually said, no worries, it's nothing, we don't need to go to a dermatologist. This unfortunately was a very bad behavior. Otherwise, anyway, he was referred to my unit in July, so after 7 months from the onset of the lesion. At the very beginning, he was in very good clinical conditions, even if he was 91 years old, no splenomegaly, no hepatomegaly. His bone marrow was not involved by the disease. There was only 0.1% of CD123 positive cells, so a really small amount of BPDCN involvement in the bone marrow. And we performed the PET-CT, as I mentioned before, and except for skin lesions, we didn't identify any other kind of lesions. He started TAG. He started TAG in August last year. During the first course, he developed legs fluid retention and thrombocytopenia, so we had to wait a little bit before starting with the second course. But as I can show you here, before TAG, this was the lesion, and at the beginning of the second day, so only after one dosage of the drug, the lesion was really changed and reduced in terms of size and in terms of colors. So, and then the patient has achieved a complete remission. He's still alive, he's in excellent conditions, and he's about to start course number 6. So a great result for an elderly patient who has been hospitalized only during the first course, and then he's living his life at home. I want to thank all my coworkers, and I will be happy to take your questions.
Thank you, Christina. Very scary in a way. But yeah, your presentation was really good. For me, there's one question, because from the surveys, sorry, that we have been running, we, for example, have data showing that when patient experience symptoms, they take symptoms even of leukemia, so the main symptoms like fatigue or bruising or the others. They don't think always about going to have a check with the GP to ask for a blood test, and it takes time. So we do a lot of work in trying to raise awareness, trying to tell people that if they experience symptoms, even if it's nothing, they should go and have a check. But in that case, it seems even more complicated. And my question to you would be, what can we do as patient advocates in our campaigns, in our awareness campaigns, to make sure, to try to at least include also those symptoms? And how can we do, what can we do also as advocates to raise awareness of this disease?
Yeah, thank you for the question, because it is the most important point. I think that the message to the patients, but also to the general people, because we are people and we can become patients, okay? Before being patients, we are normal people, is that if strange symptoms or something unusual occur, we should immediately refer to our GP at least, okay? Without waiting, without saying, I wait for what? I mean, if there are bleeding, if there is fatigue, if there is a fever which is not able to be controlled by antibacterial therapy or other strange things, I mean that a GP needs to be involved and needs to go on prescribing at least the blood tests. And the same if there are abnormal skin lesions. The direct step would be to go to a dermatologist, because the point is that, at least in my country, the GP usually, in most cases, try to underestimate the problem and saying the skin lesion is nothing bad and we can wait. But there are skin lesions, not only BPDCN, but also other lymphoma which involve skin, which may have a very, very bad prognosis. So we should work in parallel on two channels, from my point of view. On one side, on dermatologists and on GPs, in order to arise their knowledge on this topic. And on the other side, on general people, stressing the concept that if they don't feel well, they have to refer to a physician, because we can't be physician of ourselves.
That's true, but the data we have as well also show that there's a proportion of patients who needs to go 6 times or more to the GP before being prescribed a blood test.
Yes, I know. And this is a problem, because the point is that the GPs are difficult to be involved in something. I mean, dermatologists have their associations and have their conventions, so we can organize meeting or something like that in order to involve them. But GPs are a bit isolated, at least in my country. I don't know in yours. But this is the problem. That's why, unfortunately, if the step is going to the GP, it takes time then to.
So if I hear what you say, the messagings we have saying you have symptoms, go to the doctor, go and have a check is still will still be beneficial even for the disease, for this one.
Yeah,
so we should keep pushing people when they experience symptoms to go and have a check.
If not the doctor, if they say that after one attempt the doctor says it's nothing and doesn't prescribe tests, the following step is to go to an emergency unit in a hospital, in which there are other physicians, there are hematologists, there are cardiologists, and then I think that the process becomes faster. But I know, it's a problem. The problem of GPs is very, very relevant also here in my country. I mean, we see that many times they don't prescribe tests and the patients waste time.
Yeah, exactly. That's the issue we see even for leukemia.
Yeah.
So
yeah, for when the disease is so advanced, and I mean BPDCN, but also leukemia in general, I think that even if the first time the GP tries not to consider this kind of abnormalities, if the patient feels bad, he goes to an emergency unit, because with the leukemia, it's very difficult to stay at home waiting. You can try, but after a couple of days, you go to an hospital, because you can't stay there.
Yeah. Okay. Thank you.
Oh, you're welcome.
So I don't see any questions in the chat box. Sometimes people need time to actually ask questions. So as usual, if there are questions that comes to your mind and you would like to ask Christina, you can send to me via email, and I would pass this to Christina. Otherwise, thank you so much, Christina, for your time
Thanks a lot.
today. Your presentation was really comprehensive. I feel a bit more equipped for this topic now.
I will send you the slides so you can share them with all the audience.
Thank you so much. Thank you so much.
Thank you.
And yeah, as I said at the beginning, the recording will be available on the website and on Facebook as well. So, the presentation will be shared as well. And with that, thanks again for your time.
Thank you very much. It was a pleasure. Hope to see you in person.
At EHA for sure.
Yeah, at EHA for sure.
Yes.
Okay. Thank you very much.
And thanks for people who have been online as well.
Bye-bye.
Bye.
Bye.